The very same principles apply to psychopharmaceuticals and ECT. Both are very helpful in achieving recovery and rehabilitation. As I said, I believe we have much to learn from the service users and their families, and government must listen to the families who know how deficient our community services are and how the cutbacks are imposing huge additional pressures on families. We must listen to service users and families and learn how education and training can be fine-tuned to produce professionals who can best respond to the needs of patients and families going forward. Colleagues, a few years ago I received an email from a nurse in Malta who had been part of a discussion the previous week in Holland about the potential for the establishment of a European Association for Psychiatric Nurses. Following the exchange of a number of emails, the group expanded and eventually Horacio was established. We had ambitions that this new organisation might become the established voice of psychiatric nurses in Europe. Over the last few years we have passed a number of developmental milestones. Joining the European Special Nurses Organisation, ESNO, affiliating to the European Federation of Nurses, hosting our first conference in Arnhem, Holland, and then the fantastic festival in Malta, and last week our second conference or congress in Prague. But most importantly of all, over the last number of years, Horacio has become accepted by the European Union as the official voice of psychiatric nurses in Europe. Recently, our Secretary General, Roland van der Staan, has been actively involved with DG Sanco in developing EU policy on mental health. And Aisling Culhane, on behalf of the PNA, has contributed to much of the research work that is going into preparation of submissions on a variety of challenges in mental health. I am delighted that the PNA has been involved in the founding and development of this organisation. It has been great to see how members have networked with colleagues from all over Europe when attending conferences, festivals in Malta and Prague. And in Prague last week, there were over 300 delegates from 32 countries, as far away as Taiwan, in parts of China, Russia, which was amazing to meet the Russian nurses, Canada and the US, as well as all from right throughout Europe. It has been, I believe we can learn a lot from our European colleagues, and I'm sure we will inspire them also. Reverting to an earlier theme, it was great to hear from Ms. Connie Magro, who is the Vice President of EUFAMI, which is the European Organisation for Families of the Mentally Ill. I said how it challenges families face, how they rely on nurses, and how we can make such a difference to the patients and their families. And again, I repeat the line earlier on, we can learn so much from the families and from people like Connie Magro. Moving to IR, the issue of long-term actors has returned to haunt our services. The lessons of the past are ignored. The recommendations of the Commission on Nursing are binned. The moratorium has merely made a bad problem critical. We have been to the LRC on several occasions over the last year. The talks have been focused on identifying the numbers and identities of long-term actors. In the meantime, another union had a case based on an individual claim processed to the Labour Court. And the court did not deal with the claim, but recommended that inter alia that the parties enter negotiations with a view to concluding a collective agreement to deal with the position of those in long-term acting positions. We have now sought the application of this recommendation to ourselves, and I understand that a formula is to issue from the HSEA identifying a regularisation process. In the past, these have been based on 3 criteria. 1, that the post is actually vacant and not held by someone on leave of absence or career break. 2, that the actor is in place for a minimum of 1 year on the agreed date. We have sought into negotiations to reduce this to 6 months. That the actor is in place following a competitive process, but we have sought that this requirement would be varied on this particular occasion. The circular is long overdue. If it doesn't appear quickly, we may well be forced into Labour Court. I must now turn to the proposed Public Service Agreement 2010-14. Colleagues, Despite my best efforts, I have failed to find any good reason why this should be accepted by public servants. I am strongly of the view that for nurses to sign for these proposals is akin to volunteering for conscription to a HSE army, in which we surrender all rights and agree to obey our managers without protest, no matter how badly the service deteriorates. I have analysed the agreement under a number of headings as follows. Because each area of the public service is covered by a separate sectoral agreement, it is difficult to quantify the benefits or challenges for public servants overall. However, the pay provisions are equally disappointing for all public servants. For some unions, they can save jobs from outsourcing by accepting all of what is unpalatable here. However, in the health sector, there are many threats posed by these proposals. It has been suggested by some commentators there is no cut in premium pay. That is not actually correct. There is a guarantee that premium pay rates will remain at current levels. However, access to premium pay is not guaranteed at current levels. For example, the document talks of reducing staffing numbers at night and weekends. It talks of reviewing staffing numbers of increased numbers of healthcare assistants. We have sought assurances on the maintenance of access to premiums. We've had no reply. And if this guarantee does not emerge, then it would fear the imposition of further cuts for some staff, if not many staff, under a different guise. In one section, it guarantees that all existing agreements and labour recommendations remain intact. However, that's not completely true either. There is some ambiguity about this commitment. I was reassured on reading this, but during our discussions, the employer stated that the guarantee did not extend to cover the travel element of the Castle Relief formula or the agreement on closure payments. I've again sought clarity in writing, and nothing has been forthcoming. The P&A has always been critical of the health authority's emphasis on the 5-day Monday to Friday patient. It has always been a nonsense. We need a service which responds to patients' needs whenever, throughout 24/7 days a week. At least to move to the 7-day, 8 to 8 working day is an improvement for the patient and the community. However, there are a number of challenges. In an environment in which the HC has so little money, it is unlikely that there will be any widespread move to the 7-day service because of the additional cost of unsocial hour premiums. Many staff have worked a Monday to Friday roster for many years, and a move to a 7-day service could be hugely challenging to home and child minding arrangements. Change should always be managed through voluntarism and deployment of new appointees. However, in conclusion, the P&A is very willing to work with the employers, with or without an agreement, to maximise the 7-day service in the interest of patients and the community. However, we need an employer to be reasonable and realistic. The policy on redeployment raised a number of concerns. Every public servant is potentially redeployable under this. It seems you can be redeployed within 45 kilometres of your current base without any compensation. However, it is to be offered first on a voluntary basis. If that doesn't work, staff will be ordered out on a seniority basis with the junior staff out first. Existing agreement circulars are effectively abolished. There is the assurance that the agreement on the issue of HCAs remains intact. However, when this is set against the other provisions, restaffing reviews and skills mix, it is clear we will have many battles ahead on this issue. In relation to the moratorium, we continue to be promised that the Department of Finance is considering providing some relief, but our understanding of this will be very limited and will mean nothing to the majority of services. Now, I understand that last week the Department of Finance signed off on our relief in relation to the moratorium, but it provides only 100 nursing posts in psychiatry. Against a background of hundreds of retirements, 100 is a drop in the ocean. The proposed agreement is predicated on the continued reduction of public servants and is absolutely blunt and indiscriminate. It fails to recognise the relationship between patient care and staffing numbers. Indeed, the agreement requires us to sign up for reducing numbers and at the same time improving services. Now, all of you here today, we know how hard it is to maintain current services. The idea that we can further reduce our numbers and at the same time improve our services is deceitful and misleading. It is suggesting that there will be no